My name is Sumant Chug. I'm a professor of medicine at the Glomerular Disease Therapeutics Lab at Rush University in Chicago. Today, I'm going to talk to you about the current and the future treatment of minimal change disease or minimal change nephrotic syndrome, um, with a sort of a focus on adults, since that's the patient population that I see. And we will also be discussing some disease mechanisms. This is my conflict of interest slide. Tells you, in addition to my university position, I have a startup company and these intellectual properties. So here are some references that I would suggest that you read. If you had little time, you would just read the first one. This is a review article that summarizes the two original discovery studies, the 2011 study and the 2023 study. So the review article summarizes both of these studies. And then this is just KDIGO 2021 clinical practice guidelines that most of you are probably already familiar with. And so I'm going to start first with this slide. And this is a slide which goes into the mechanisms of minimal change disease. So way back in 2011, in Nature Medicine, we showed that in human minimal change disease and experimental minimal change disease, you have very significant upregulation of a protein called angiopoietin-like 4 in podocytes, and the protein is hyposialylated, which means that it has fewer than normal sialic acid residues, and that the upregulation of this hyposialylated protein or low sialylation form of angiopoietin-like 4 creates most of the cardinal manifestations of human minimal change disease, including massive and selective proteinuria, loss of glomerular basement membrane charge, and diffuse effacement of food processes, and the other common manifestations of hyperlipidemia and nephrotic syndrome. Fast forward to the 2023 study, and we showed the first genomic basis of human minimal change disease, where we described a shared insertion about 500,000 base pairs upstream of a gene called zinc fingers and homeoboxes 2 or ZHX2. And this shared insertion was replicated using CRISPR-Cas9 in cultured podocytes and showed that it causes a ZHX2 hypomorph state, which means a low ZHX2 expression state. So patients with MCD and some patients with FSGS have a low hypomorph expression state. Now, how does then that differentiate into the two studies? If you read the review article, I show you the multi-tiered hypothesis and pathogenesis of MCD versus FSGS. I don't want to go into that in detail right now, but read about the multi-tiered pathogenesis. They may start similarly, but then they branch apart. In addition, in the new study, we showed how common colds can actually induce relapse of minimal change disease. So about half of the patients who relapse have a relapse of MCD have a common cold. In addition, half of these MCD patients have chronic atopy. So if you combine the mild cytokine storm associated with a common cold, to that you add the elevated levels of the soluble interleukin-4 receptor alpha, which is common in chronic atopy. Remember, we're talking about chronic atopy, not acute atopy. Acute atopy is associated with increased levels of IL-4 and IL-13. No, I'm talking about chronic atopy. So if a patient is a ZHX2 hypomorph, has chronic atopy, which means has high soluble interleukin-4 receptor alpha levels, and then develops a mild cytokine storm due to a common cold, that patient will undergo relapse. And that is shown to you in this particular figure, the ZHX2 hypomorph state. So to understand these figures a little bit better, you could go ahead and read the review article. But these figures show you, make certain points very clear, that minimal change disease is essentially a disease of the body of the podocyte. It is not a disease of the slit diaphragm, right? By contrast, when you read the review, you'll understand that FSGS then becomes a disease of the foot processes, in specific the slit diaphragm. So when you talk about minimal change disease, think of the body of the podocyte. And when you think of FSGS, think about the slit diaphragm and the foot processes. That's how the pathogenesis is explained, right? So in a ZHX2 hypomorph patient, there's a lot of ZHX1 that goes and upregulates angioportal light. But you're better served of reading the review article. And as I mentioned to you, in 2011, we showed the hyposialylated form of angioportal light 4 that goes up. Now, when you have upregulation of podocyte angioportal light 4, some of it is sialylated and has a very strong anti-apoptotic effect, which means that, which is exactly why patients with MCD do not get, podocyte depletion or interstitial fibrosis. But some of the sialylated angioportal light 4 also leaks into the circulation and induces hypertriglyceridemia. The hyposialylated protein, which is the dangerous form of the protein, right? It actually causes injury. It causes injury through integrin-dependent effects and endocrine-independent effects, which are largely related to proteoglycan binding. So this is a phenomenon of hyposialylation injury, which is initiated by angioportal light 4. But then there are other players that come on later on that actually perpetuate the hyposialylation injury. And then there is a form of hyposialylation injury that is more chronic, and that affects reduced availability of sialic acid in the podocyte to sialylate proteins, for example, like podocalyxin. So this is an acute hyposialylation. This is more of a chronic hyposialylation. But in all, hyposialylation injury is the real basis of human minimal change disease pathogenesis. So how do we treat minimal change disease? So all of you have access to KDIGO 2021. There is an older version, KDIGO 2012, but I would suggest that you look at KDIGO 2021. This cartoon or this flow sheet is actually from KDIGO 2021. And so when we talk about MCD, we typically start by treating with glucocorticoids if there's a contraindication. So here, no contraindication to glucocorticoids, we start with glucocorticoids or steroids. If there's a contraindication, we start with other agents. The preferred way of treating it as of now is really glucocorticoids. You could read the detailed regimens in KDIGO 2021. The doses recommended by KDIGO are quite high. I have actually never used the 1 milligram per kilogram per day dose in adults. I typically use much lower doses, somewhere in the tune of 0.75 milligrams per kilogram per day, and even sometimes even lower. And patients usually respond in case of minimal change disease. And then, how do you treat relapse? So these are definitions of complete remission, partial remission, relapse, steroid resistant, frequent relapse, and steroid-dependent MCD. These are all derived from KDIGO. And so what I want to tell you is that frequently relapsing MCD, is often treated either with cyclophosphamide or with some of these other agents. But I'm now going to go back to a previous slide that I showed you and tell you how we are actually going to be treating minimal change disease in the future. So I'm going to go back 2 slides here, and let's look at this slide. So as I told you, in 2011, we showed that angioportal light 4 goes up, initiates the hyposialylation injury, right? And then the acute hyposialylation injury leads to a phase of chronic hyposialylation injury. So the first thing we would like to do is improve the sialylation. So whereas you treat with steroids and cyclosporin and cyclophosphamide, in the future, you will not be doing that. We will be treating the primary defect, which is the hyposialylation injury. That is point number 1. Point number 2, in patients who relapse frequently, there is now preclinical data showing you that these patients who get frequent common colds and immediately get relapse within a few days, the preclinical data suggests that depletion immediately after the common cold develops, if you deplete either TNF alpha or IL-6 or the soluble interleukin-4 receptor alpha by injecting antibodies, you could very well prevent relapse of MCD in these patients. Okay, so but these are still preclinical data, and the clinical studies have yet not been done. So the two things I'm going to go back to go now to my last slide and reiterate some of these things that I've just said to you. So the first thing is that future therapy will rely on correction of the cellulation defect. Now, we started doing this in preclinical studies using a compound called N-acetyl-D-monosamine, which very well reduces proteinuria and nephrotic syndrome in experimental animals. But as we were doing due diligence with MANNAC, this is a modified sugar, right? We noted that MANNAC is a very promiscuous sugar in that it induces O-glycanylation of multiple proteins. And for those of you who are not familiar with O-glycanylation, it is one of the major manifestations of the diabetic state. So even though MANNAC does not cause diabetes, it induces O-glycanylation of multiple proteins. And if you were to use this in the long term, you would have a part of a profile that is similar to diabetes, right? Without having diabetes, right? So we stopped using MANNAC, several years ago, and now we are developing additional compounds that will improve the cellulation. But the mainstay of future therapy of MCD will be by improving cellulation. And as I've also mentioned to you, to prevent relapse, infrequent relapses, the preclinical studies support the depletion of TNF alpha or IL-6 or interleukin-4 receptor alpha immediately after the onset of a common cold. Certainly within the first, say, 48 hours or so, 48 to 72 hours before, the relapse develops. So if we deplete it, then there is a possibility or a high likelihood that in the clinical studies, this may prevent the relapse. Now, the antibodies are available. The clinical studies have yet not been done, right? So this is an open, this is quite open. The preclinical work is published in 2023. For those of you that are interested in conducting these clinical studies at your own center, you could easily file an IRB and conduct a normal clinical study, even in a small number of patients, if you are convinced of the data. But for that, you would have to read the 2023 paper. So here is how the future treatment of minimal change disease looks. The first episode of biopsy-proven MCD in the future will either be treated with glucocorticoids or with a future cellulation improving compound. I mean, we could have used MANNAC, but MANNAC has side effects. So remember that angiopoietin-like 4, the protein that goes up in podocytes, is a very glucocorticoid-sensitive gene. It goes up, the glucocorticoids reduce the expression. But glucocorticoids have multiple side effects. So we do not want to use glucocorticoids in the long term. So the first episode could be treated with glucocorticoids or a cellulation-inducing agent. All future relapses would only be treated with a cellulation-improving agent, period. No steroids. And in the future, if the clinical trials show that this kind of therapy works, then patients who relapse frequently after a common cold could be treated with antibodies directed against TNF alpha or IL-6 or the soluble or IL-4 receptor alpha. So with that, I'm going to stop here. And I'd like to thank Dr. Carmen Avila Casado and members of her group and your society for this very kind invitation. I would like to thank members of the Glomerular Disease Therapeutics Lab, which is my research group, for all the hard work we put into developing therapeutics, studying mechanisms. And I would, of course, like to thank the National Institutes of Health, and specific NIDDK, for research funding. Thank you for your attention. If you have any questions, please feel free to email me at sumant_s_chug@rush.edu. Thank you.